Is the traffic in Hamburg so bad that you often take your sub? What is the most adventurous thing you ever have done?
I don't know if I'm going to tell that.
With cryoablation, we have the great opportunity to challenge indications in AF ablation because we already have really good data.
What do you think need to be done with regards to females or women in EP?
With cryo, this is different. It is implemented in our daily workflow. We don't have extra costs using it, so this is definitely still a benefit of the technology.
It is very funny.
Can you tell me how you became the ice princess?
I have no idea.
Welcome to the Stay Cool podcast. I'm Rolf Meyer, Director Clinical Research at Medtronic Cardiac Ablation Solutions. This podcast is about people that share their dedication for electrophysiology and for catheter ablation. We are going to meet people on their way to work. And this might be people you maybe have seen already on the podium. And we would like to learn more about the person that are behind this. This morning we are going to meet with Dr. Melanie Gunawardene from the Asklepios Clinic St. George in Hamburg. She's a senior physician at the clinic, having spent already a lot of time on clinical research and AF ablation. And there she is coming. Hi Melanie, this direction. This is a strange place to meet, but she proposed this meeting place just directly at the waterfront. Look at her, she's coming over to us. Is the traffic in Hamburg so bad that you often take your sub?
Yeah, definitely. You see it's totally empty on the water, but the streets are very full and it's very nice and calm. Being out in nature in the morning, I love it.
It looks fantastic.
Hi, good morning.
Good morning.
Well, maybe you need to give me a hand so I get out.
Yeah.
Thanks. Thank you. Now we have to get the sap out of the water, Ralf. Okay, let's try this. Oh. Don't fall.
No, I'm not falling.
Okay. Thank you. Okay. Nice.
So I think let's bring it back to your car and then go to work.
Good. Yes, do you want to help me carry it so we can go to the hospital?
Yeah, sure, let's go.
Thank you so much. So this is my car.
That's nice.
Yes, a little camper van for the weekend. What? Sorry. Thank you for the help.
Sure.
So because you're such a great helper, I would invite you in for a little conversation and maybe make you a coffee if you want.
You have a coffee maker? Yeah, sure, definitely.
Yeah? Okay, let's do this.
I already hear the Bee Gees singing in the background.
Yeah, come in. You can also sing if you want to.
Oh, not yet. Not yet. Next time.
Okay, here you go.
Ah, thanks a lot.
You're welcome.
Perfect.
Enjoy your coffee.
Real coffee. Thanks a lot.
Cheers.
While we are sitting here, we would like to learn more about you. So a bit about you as a person. And I did prepare 10 quick fire questions.
Ooh-ha.
Are you ready for it?
I guess I have to say yes.
What is the most favorite thing about your job?
Do you mean as a doctor or as an electrophysiologist?
As an electrophysiologist.
Okay, because as an electrophysiologist, I would say the complexity and the challenge that you face every day is what I love the most. But if you ask me as a doctor, then I think that I can really contribute to society and my patients that I care for. So I would make a little differentiation between those two things maybe.
What is the most adventurous thing you ever have done in your life?
I don't know if I'm going to tell. No, I'm just kidding. So I like to travel a lot. And I would say most recently, the thing that I did, and I even thought about my boss while I was doing it, because I was like, does he really know what I'm doing when I'm off work? We did a trip to Chile, and there was a big swell coming in, and there was a 3.8 meter wave. And I went kiting inside of that. I don't know, it was so much adrenaline, it was so fast, and I was just lucky when I got out again that I challenged myself to do it. But yeah, that was probably the most adrenaline I have felt in a long time.
What is the best advice you ever received?
to keep cool. No, just kidding.
Which is a good advice.
Yeah. Maybe. Okay, so I did a coaching once because I'm a kind of a control freak because I just want everything to be good and perfect and efficient. But sometimes there's a lot of things you need to juggle in life, whether it's private or in the job. So somebody told me to advise that when things are a lot to manage, that you need to stop thinking about the bigger picture for a moment and just take it step by step and stay in the moment, focus, and face every challenge that occurs. And I think that in times when I'm struggling, this is really helping me to kind of unwind and calm down again. So I think that was a good advice.
What is something you're passionate about that not many people know?
So the first thing I think that I'm passionate about, but everybody knows about, is that I'm a kite surfer. So I definitely have to mention that because I just love to do that.
Yeah.
So I don't know. I'm a passionate aunt. Maybe that's something people don't know that much.
That's a good one.
Yeah, I love my niece. Love spending time with her. I love how honest children are and straightforward and energetic. It's always good. They have a lot of energy. So yeah.
Yeah. So for all of you that are listening to our audio podcast, I brought with me a nice doll, which is from Frozen, and it is his so-called ice princess.
That is very funny.
Can you tell me how you became the ice princess?
I have no idea really how I became that. I noticed people started calling me it, and I think I did some studies early when I was still in residency about cryo, and we published some data, and then we started the Emerge Cryo study. I think we want to talk about this later as well. And that just, I don't know. And then people, I don't even know who started it, but it started to appear, and now it's just really how people address me. But
yeah, this is Elsa, and as I've heard, she's also doing a lot of free time. Yes.
She's not on ice as much.
Yeah, of course she's also nice. I was wondering, when looking at your CV, how did you get into electrophysiology? Was there a specific situation or a specific person that got you into electrophysiology?
Yeah, it's actually quite an, I think, cool story for myself that I really like to look back at too, because so when I was a medical student, I was like 21 or 22 years old, and I had this bedside teaching course from Professor Vogtländer, who's now in the German Heart Foundation, and he talked about ECG of a patient, and I just looked at all the curves and I didn't understand anything he was saying. So I was like, this must be a very intelligent person, and I asked him if I could join him for an internship. So he said, yes, I'm in Frankfurt. So I was like, oh, that's fine. My sister's living there. So I spent a whole month there, and every day during roundings, we would send patients to the other hospital because they're working in two hospitals to get an electrophysiology study and ablation. And I was like, what is that? So they said, oh, you can go and have a look the last day of your internship. So the last day of my internship, I went into the EP lab and I met Professor Chun and Professor Schmidt from CCB in Frankfurt, and they were doing cases, and it was just a great energy. They were having a lot of fun and very entertaining. It looked super complex what they were doing, and I just had a really great day with them. And then they asked me at the end of it if I wanted to start doing a doctoral thesis with them, and I said no, because I thought this was much too complex. So I was like, never. And they were just like, give it a thought, we will have a conversation. And so they followed up on me, asking me again, and I said, under one condition, if I do not have to learn how to read an ECG, I will do it.
So this is also a great opportunity for you to influence. And what do you think need to be done with regards to females or women in EP?
Yeah, that's a very good question, and I get that question obviously a lot because I am one of the few female electrophysiologists that are out there. And I think, as I said in what I just told you, I was afraid in the beginning as well. I thought, this is challenging, I'm not smart enough, how can I, become such a person? And I think the way forward is just to go ahead with it and lean in and keep doing it, and not decide for yourself before entering this path. And I think this is how you need to get to the women early on in their career already and show them that it's feasible. I'm trying to be a positive role model whenever somebody is trying to get an advice. I'm just very honest also. It is a lot of work. It's not that you get it for free and you can just smile your way around as a girl and that's how you become a leader or an electrophysiologist or anything. It is a lot of work, it's true. But I think we are a next generation. We are self-sufficient women. We take care of ourselves. We can also take care of our career. And it's just going forward with it, really, and to be motivated, to see how others are doing it. Yeah, and I hope that some see what I'm doing and actually think, oh yeah, well, she's still a normal human. She has a life and she's still an electrophysiologist. You can be everything.
You mentioned that you have 2 cases being scheduled for today.
Yeah.
I'm wondering if it's now time getting over to the hospital
Yeah.
to make sure that we're in time for the patients.
Yeah, we should do this.
So guys, here we are. This is our emergency department. Let's see if they have something for us to do.
So this is the place where all the patients come in.
Yes,
from the area of
exactly.
Hamburg in case of emergency. So it's a very important place.
Yes, absolutely. It's where we have our cardiac arrest center and chest pain unit, where Dr. Jan Wietz, who's the head of the department for the ER,
Nice meeting you. Good morning.
takes care of all the patients. Good to see you.
Yeah, good to see you. Good to have you here. I think we do have a patient, a potential patient for your emergent cryo study.
Nice. Let's
Yeah.
have a look at the case together.
Please follow me. This is the ECG. Maybe you can take a look.
Yeah, great. So we have a patient here who converted from atrial fibrillation to sinus rhythm again. Sounds like it's a perfect candidate. And you didn't have any antiarrhythmic drugs before?
No, I don't think so.
Perfect. So let's ask the patient if he wants to participate in the study. And thank you so much for taking a closer look and providing us with the patient.
Yeah.
And I think Ralf and I are going to head out to the EP lab, do some procedures, and we leave you to it.
So Melanie, we just have been entering the hospital through the emergency unit, and it was great to see the emergency unit. And you mentioned the Emerge Cryo study. So what is this about? Can you explain it a bit to us?
Yes, of course. So the Emerge Cryo study is a study where we randomize patients that are actually admitted through the emergency department. With cryoablation, we have the great opportunity to challenge indications in AF ablation because we already have really good data about the first line therapy, about cryo, for example. And so we have a lot of this discussion that we need an early ablation in our patients, right? Because we know AF is a progressive disease and we need to hit it early. But what is early and how do we define it? And do we maybe also define it by the urgency on how it presents? So the patient who comes into the emergency department, is he better off getting a cardioversion and an antiarrhythmic drug, for example, or should we ablate those patients right away? So in that study, we randomized 350 patients to either direct ablation within 14 days after admission to the emergency department, or they will get antiarrhythmic drugs. We also implant loop recorders in all the patients so that we can follow them up continuously. And this is something that I think is really great about the study because we can really get an intuition about and also a feeling about the real AF burden, and we measure it.
I think you also enrolled a while ago patients into the Cryo First study, which was a study on first-line treatment using the cryoballoon. What is the role of first-line ablation here in your lab? Are you seeing first-line patients regularly?
Yes, definitely. And especially because I think we have 2 very interesting cohorts that we target. It's the very young people, they're in their early 40s and 50s. They have, they're very active in their daily life, and an antiarrhythmic drug to them doesn't seem something they can really put into the daily activities because either they don't feel good, maybe also even on a beta blocker, they want to be active, they want to do their sports. We have patients who are marathon runners or something like that. They want to stay active, so an antiarrhythmic drug doesn't really do it. And on the other side, we have those really older patients and where we know we have the problem that they face bradycardia and all those side effects of antiarrhythmic drugs. So even if those are totally different cohorts, we feel like for both of them, the antiarrhythmic drug isn't always the best thing we would kind of recommend to them. And so a lot of them already There's a lot of things in the internet they can read up on from the German Heart Foundation, also patient information, and they also they look it up, and a lot of them have a wearable themselves. They detect the AF, and before they even go to the doctor, they start reading on it, and a lot of them come into the hospital asking for an ablation nowadays as well. And if you tell them what the different treatment options are, then I must admit that a lot of them choose catheter ablation over an antiarrhythmic drug trial for them.
How do you see the role of cryoballoon ablation now and in the future, especially with other technologies coming up?
So I think right now cryo still plays a big role in our lab also, because I think it's a really reproducible and an easy to learn AF ablation. It's the perfect tool to learn how to get to the left side of the heart. You have one sheet that you need to navigate, and you have one catheter. You can estimate how good is my occlusion. You have some parameters that you measure while you ablate that can guide your ablation, like the time to isolation that you see. And in this way, it becomes kind of a technology where even for example, when I'm teaching a fellow, I see exactly what the person is doing. I can take control of the things, like from the outside. I can tell people to push more to get a better occlusion and guide them better through the ablation. And at the same time, I see that it is not so much dependent on the operator. For example, when you have a point-by-point ablation technology, it is much more dependent on the operator's skills and the level of where he is at, for example. I think this is a great technology. I think even in the times where we have a rising incidence of AF, we have more patients coming in, we need ablation technologies that are fast and that are good for our patients and safe. And I think cryo has an overall really great safety profile. Of course, now we have PFA, and I think it's also a great technology, and I love the PFA way forward. The problem that we are facing here in Germany especially is still that we have increasing costs with that new technology. So it's not like this is what we can use in every patient every day, right? With cryo, this is different. It is implemented in our daily workflow. We don't have extra costs using it, so this is definitely still a benefit of the technology. But also we know with PFA, and I really enjoy pulse field ablation, as you all know, and I think it's a great technology, and I think it's also a way forward. But right now we don't have data that really tell us that it is better in regards of efficacy. So we still need also to improve that technology, but also we're talking about a first generation device that we're all using compared to cryo that we already have in our fourth generation, right? But I think we need to have more data on it and see how much better can we get. Right now we're not better, so there's no rush to change everything. I'm excited to see how the field is moving forward.
I do have a more technical question to you now. With the launch of the new NITOM system, how did it change your workflow within the cath lab?
Yeah, I think it really improved the workflow. It was already very improved because we're a big cryo center. We've been performing cryoablation for more than 10 years. So we were first skeptical. Is this really going to improve anything? I mean, we're already fast and good at what we're doing, to not sound arrogant, but that was something I was like, okay, this is new now, but what is it really going to bring to the table? And what you must say, it brings the state-of-the-art new interface. We have a remote control, and with that we can really be more precise. We can really tag our time to isolation more precisely. We can also stop ablation if we need it really quickly without turning around. You can have everything in front of you. You see your screen, you have your patient. You don't need to, turn and do things. You have it in your hands, sort of, to say. And I think then also you can get the clinical data out much easier, which also is really helpful because we have the clinical studies going on. So this really improves our workflow in this regard.
I know that you have been also using the FlexGas Cross already. So what about this sheath? How does it translate into your cath lab?
Yeah, so I think a good advantage is that you don't have to exchange sheet. You only have to put one sheet in the LA and you can stay. And I think the less we exchange sheet, the better it is for our patient, because then you don't have this fear of air getting into the left atrium, right? This is something that I think is important, especially with the transeptal puncture. I think that is the crucial step in the procedure. It's where you can harm your patient and where you need to be very confident. So whatever brings confidence to you in your procedure as an electrophysiologist is what you should choose. If it's the old way because you're used to it and you feel confident, or if it's a new technology that can help you improve your skills, that guide you better, whatever it is, I think is the right choice for you as an operator.
A final question from my side is, there's a significant increase in the need of AF ablation, and you're quite young in your career as an electrophysiologist. How do you see this area evolving in the next 5 or 10 years? So what might be the cath lab looking like for you, the working environment in 5 to 10 years, where you have to even treat more patients than today?
Yeah, that's a good question. I think that we already came a long way when you think about how long an AF ablation used to take. I haven't been around those times, but I hear it's been up to 8 hours or something. And now we're doing ablations, PVI, in like half an hour to 60 minutes with either single shot technology that we have. So I think this is already really fast, and this means that we can use our lab more efficiently in the time that we are having during the day, and we can do more procedures. So with an increasing AF incidence, it is possible with those single shot devices, and the data right now only tells us to do a PVI, right? Even in persistent patients, we're not there yet that we have those randomized data that tell us you need an extra ablation strategy. So right now, to provide a patient with a PVI only approach in a first do procedure is absolutely something you can do, and you should even do. That's what the guideline says. I'm excited to see what the new ones will bring in the summer, but as of my knowledge, there is some trials that tell you that in persistent AF you can benefit from extra ablation strategies, but there's not this perfect cooking recipe that we can all use every day in the lab. So I think with a single shot device you can provide a reproducible, fast and safe PVI for your patient. You can treat more patients. It is less operator dependent, which is also good because you need to train a lot more physicians and electrophysiologists, and it can take some time to do the training. We've all been through it. For myself, I was sitting outside for 1.5 years only looking at electrograms before I got my first catheter into my hands. And I think we have passed those times. We don't have time and resources anymore to have someone sit outside for 1.5 years. So with those technologies, I think it is also feasible to get younger doctors into the left atrium and perform PVI so that we can treat more patients in the future, because they will come. Another aspect that's being discussed in our community definitely is, can we do it with same-day discharge? Those kind of things, right? There's also optimization. So there's a lot going on, there's a lot coming, and there's a constant improvement and optimization of how we're doing things in electrophysiology.
Melanie, many thanks for all your time this morning. Many thanks for all the insights. Especially the way from your home to work was impressive with the stand-up paddling. Thanks a lot for that. So we are coming to the end of this podcast, and I would like to thank the audience for listening, but also watching this. And there's the next one coming up soon, and we invite you to also join the next podcast. Stay cool and stay connected.